Hello to every smartness out there. Welcome to today's teaching and learning session. Do you know that hypothyroidism, hyperthyroidism, galactosemia, and phenylketonuria always appear in general paper as well as the medical nursing and sometimes surgery? And so smartness tutorial want to review these important topics with you by with what the NMC past questions. Hope you're happy. All right, so let's get started. The first question says hypothyroidism in children is most commonly caused by A. Autoimmune thyroiditis, B. Iodine deficiency, C. Overconsumption of iodine, and then D. Viral infections. Now, so what is the correct answer here? Yes, your answer in the comment section. Now let's look at the correct answer here, which is A. Autoimmune thyroiditis, which is also known as what? The Hashimoto thyroiditis. Now, hypothyroidism. We can have congenital hypothyroidism, hypothyroidism in children, and then also hypothyroidism in adults. When we talk about hypothyroidism in children, the main cause is what? Hashimoto disease or autoimmune thyroiditis. Yes, iron deficiency can cause it, but in children, the most common is what? Hashimoto disease. And when we talk about the neonate, which is the congenital, or when we look at the congenital hypothyroidism, the main cause has to do with what? Thyroid dysgenesis, meaning the thyroid gland was not well formed. Okay, which congenital hypothyroidism can also occur as a result of what? Agenesis. That means that the thyroid gland was not even formed at all. Or we can have hyperplasia of the thyroid gland. But as I said, the main cause of congenital hypothyroidism is thyroid dysgenesis. And in children, it is what? Hashimoto thyroiditis. In adults, it is what? Iodine deficiency. Okay. All right, so let's look at the second question. Question 2. A 10-day-old neonate was diagnosed of hypothyroidism based on clinical assessments and laboratory investigations. Which of the following is not a clinical characteristic of hypothyroidism? It's not a clinical characteristic of hypothyroidism. Yes. What do you think is the answer? In the comment section. All right, so let's look at the correct answer here, which is B. So we are saying that in hypothyroidism, there's low amounts of T3 and T4, which can lead to post-maturity, large posterior frontal, and then umbilical hernia, but not preterm. Why? Now, the T3 and the T4 are hormones that one of their role also is to help in initiating labor. So if the hormone is low in circulation, that means that there's going to be a delay in initiating what? Labor, and that can lead to what? Post maturity, but not what? Preterm. So that means that in hyperthyroidism there can be what? Preterm labor or what? Preterm. Okay. All right, so when you look at the question, it is really talking about congenital hypothyroidism. Okay, so their clinical features is about post-maturity, large posterior frontal, and then what? Umbilical hernia. And I've given you a mnemonic over here, which is what? Puffy face. The puffy is just saying that the baby is going to look what? Puffy, edematous or myxedema. Okay, the F stands for frontal. Okay, in the frontal we are looking at large posterior frontal. And then the A stands for ascites. As I said, the baby is going to what? Edematous. And the C stands for constipation. That means in hyperthyroidism, we expect the baby to have what? Diarrhea. Okay. And the C again also stands for caused face. And the E stands for enlarged tank, which is what? Microglossia. Okay. All right. So let's look at this third question. The third question says a newborn has been diagnosed with hypothyroidism. In discussing the condition and treatment with the family, the nurse should emphasize A. They can expect the child will be mentally retarded. B. Administration of thyroid hormone will prevent problems. C. This real problem is always hereditary. D. Physical growth or development will be affected. So, what do you think is the correct answer when you're educating a family whose newborn is having hypothyroidism? Yes, the correct answer is B. Now, when you look at the question, the stem of the question, in educating a family member, okay, whose ward or kid is having hypothyroidism, you will educate the patient on all this A, B, C, D, but we are looking at the one you stress on. We are looking at the most important one, and we are saying the answer is what? B, because early and lifelong initiation of treatment with levothyroxine will help to prevent intellectual disability and also improve growth and development. And so the treatment will prevent the A, which is mental retardation. Sorry, initiating treatment will also prevent a developmental uh, deficit. Okay, so the correct answer is what? B. That means that anytime the diagnosis is made, treatment is supposed to be what? Initiated. Okay, so that can also be a question for you. Now let's look at the fourth question here. Which of the following is not a treatment option for hyperthyroidism? A. Thyroidectomy. B. Metimazole. C. Liothyronine sodium, which is cytomel. And then D. Radioactive iodine. Yes, the correct answer in the comment section. Okay, so the correct answer here is C. Now, in hyperthyroidism, there's excess production of T3 and T4, which is the thyroid hormone. In managing it, we can do thyroidectomy, removal of the thyroid gland, yes. And then the drug, the anti-thyroid drug that we give is what? Metimazole. So it can be given. And then we can also do a radioactive iodine, which will also help in managing the hyperthyroidism. But liothyronine cannot be given because it is used for hypothyroidism. And so when you use it, you are rather going to what? Worsen the situation. Okay, so the correct answer is C. The next question, question 5. Miss Gilmore is complaining that her 5-year-old boy is being hot all the time, sweating, being thirsty, and losing hair. What could her symptoms indicate? A. Hypothyroidism. B. Hyperthyroidism. And C. Graves' disease. What do you think is the correct answer here? Yes, in 5 seconds. All right, so the correct answer here is B. Now they have given you the stem is the stem has given you symptoms and they are asking for the diagnosis. Okay, which is what? Hyperthyroidism. Remember, when your T3 and T4 is high, it's going to lead to heat intolerance. Why? Because the thyroid hormone helps to increase body temperature. So if it is high, it means you're going to have what? Heat intolerance. But if it is low, you're going to have what? Cold intolerance. But here we are looking at a situation whereby what? There is hyperthyroidism. And so the baby or the child is going to feel hot all the time. And since the child is feeling hot, the negative feedback mechanism or the body's own way of correcting is what? Sweating to cool it down. And the sweating also, you are also what? Losing fluid. And so the body will cause you to increase the test. And that is why in hyperthyroidism there's what? Heat intolerance, excessive sweating, and then what? Uh, being thirsty. And the thyroid hormone in hyperthyroidism is also associated with losing hair. Okay, all right. So let's look at the next question. A client has been newly diagnosed with hypothyroidism and will take levothyroxine, which is what, a synthroid, 50 microgram per day by mouth. As part of the teaching plan, the nurse emphasized that this medication A should be taken in the morning, B may decrease the client's energy level, C must be stored in a dark container, and D would decrease the client's heart rate. So you give the drug levothyroxine to the patient's mother. What teachings will you give to her in relation to the administration of the drug? Very important. Okay. All right. So what is your answer here? The correct answer here is A. We say chemically, levothyroxine is what? A synthetic form of tyrosine, which is the T4, and that is derived from the amino acid. And so the levothyroxine sometimes behave like what? A weak acid. And so for the drug to have its therapeutic effect, it is expected that it is being administered before meal, at least 30 to 60 minutes before meal, and that will enhance a greater absorption to enhance what? Its therapeutic effect on the treatment. Okay, so that is the best teachings to be given to this family member or the patient. Okay, all right. Now let's look at question number 7. If 3-month-old client is in the pediatric unit during assessment, the nurse is expecting that the baby may have hypothyroidism when mother states that her baby does not do what? A. Sit up. B. Pick up and hold a rattle. C. Roll over. And then D. Hold the head up. So what do you think is the correct answer? Yes. Mm-hmm. The correct answer here is D. You see, this question, you don't really need only hypothyroidism to solve it, but what? Developmental milestone, because the options all are talking about a developmental milestone, and the key word that we need to concentrate on here is what? The age, a 3 months. So what do you expect a 3-month old baby to do at that age? Sit up? No, because babies sit up by 6 months with support, and without support by what? 8 months. But this baby is what? 3 months. So it's no. Pick up and hold a rattle, and that is being done around what? 3 to 4 months. Roll over is also done within 4 months, and some books will say 4 to 5 months. But 3 months, we expect that every baby will gain neck control. So if the baby did not get neck control by 4th month, then that baby needs to be referred to see what? A neurologist, because there should be problem with what? The central nervous system. Okay, all right. So let's look at the next question. All right, so now we are done with hypo versus hyperthyroidism. Now let's look at galactosemia and phenylketonuria. I hope you enjoy this one too, just like how you did for the first one. All right, the first question on galactosemia versus phenylketonuria. Which of the following enzyme can cause galactosemia when there is severe deficiency in the neonate's blood? A. Galactose 1 phosphate uridyl transferase. B. Galactose 1 phosphate pyruvic transferase. C. Glucose 1 phosphate transferase. And then D. Glucose 1 pyruvic transferase. So what do you think is the correct answer here? Is it A, B, C, or D? The correct answer here is A. So you see, when you look at the stem of the question, it is just asking you for the cause of galactosemia, the enzyme that when it is absent, its deficiency can lead to what? Galactosemia, and that is all. Okay, and that is what? Galactose 1 phosphate uridyl transferase. Okay, so what the enzyme does is that they convert galactose into what? Glucose. And so if this enzyme is not there, okay, if it is absent, then it means that galactose is going to be built in the blood, and that will lead to a condition known as what? Galactosemia. Okay, all right, and this condition we say it is what? A recessive inherited metabolic disorder. Recessive means what? We need two defective genes, one from the mother, one from the father, before the person will exhibit the clinical features of what? Galactosemia. That means we can have a baby with what? A carrier. All right, so remember that word, it is recessive inherited metabolic disorder. All right, now let's look on to the next question. We said Madam Chome reported at the clinic with complaints that her 4-week-old failed to gain weight, failure to thrive, right? Vomiting, and was suspected of having galactosemia. What other two signs would confirm this diagnosis? A. Hypoglycemia and hypokalemia. B. Bleeding and liver failure. C. Liver failure and renal impairment. So here we are looking at clinical features, the hallmark, yes, the hallmark clinical features of galactosemia. Okay, all right. So what is your answer? All right. So the correct answer here is C. So you see, in galactosemia, as I explained earlier on, galactose is not being converted or metabolized into glucose for the body cells to use. Okay, so there's hypoglycemia, and there's excess accumulation of galactose in the blood. When there's excess galactose in the blood, it can damage the liver, damage the renal system, and damage the eye. Okay, so the hallmark feature of galactosemia is three: liver failure, renal impairment, and then failure to thrive. Baby is not getting the glucose. How can the glucose for the cells to you? How can the baby thrive? The baby grow? No. Okay, and for hypoglycemia, yes, but not hypokalemia. Bleeding disorder, yes, it can also lead to bleeding disorder because the accumulation of the galactose in the blood can also damage the liver, which the liver cannot perform its function in relation to synthesis of clotting factor, okay, which can lead to bleeding. But that is not a hallmark. Okay, the hallmark is what? Liver failure, renal impairment, and failure to thrive. Now let's look at the next question. Madam Susie Nyamiche reported that her 3-week-old infant cannot tolerate breast milk. The baby presents with skin rashes, seizures, musty odor in breath, and urine, which of the underlisted conditions is the baby likely to be suffering from? Select one. A. Hypothyroidism. B. Hyperthyroidism. C. Phenylketonuria. And D. Galactosemia. So what do you think is the correct answer? Yes, a 3-week-old baby presented with skin rashes, musty odor when breathing, and then in urine, yeah, and then also having seizures. Mhm. All right, so the correct answer here is C, phenylketonuria. Now the question is, what is phenylketonuria? Let me use just 1 minute to explain this condition to you. Phenylketonuria is also one of the recessive inherited metabolic disorder that occur when there is absence of an enzyme known as what phenylalanine hydroxylase. Okay, this enzyme is responsible for converting phenylalanine, which is a protein, into tyrosine. Okay, and so when the phenylalanine is not able to be converted, okay, from that phenylalanine state into tyrosine, you are going to have accumulation of phenylalanine in the blood, and that will lead to a condition known as phenylketonuria. Okay, and so with phenylketonuria, or simply known as the PKU, it can lead to seizures because the tyrosine that was not produced because we could not convert the phenylalanine into tyrosine. This tyrosine is used in producing dopamine, and the dopamine helps in smoothing the activities of what? The acetylcholine. Okay, so acetylcholine normally what? Excites cells, which can lead to seizures. And so since you don't have dopamine to smooth it, the baby will have what? Seizures. Okay, and then the phenylalanine in urine gives this odor, which is what? Musty, and this breath, which is also what? Musty, and can also lead to what? Skin rashes. Okay. All right. So we are saying that the hallmark of phenylketonuria PKU is what? Musty or muzzy odor. Okay, in breath and urine. All right. Let's look at the next question. Baby Kojo was referred from a secondary health facility to a tertiary hospital on account of unresponsive hypoglycemia and prolonged jaundice. What will be the possible diagnosis of the baby? A. Pathological jaundice. B. Phenylketonuria. C. Hyperkalemia. And then D. Galactosemia. Alright. Okay. So what do you think is the answer? What do you think is the answer? Okay. Alright. So your answer in the comment section and a rationale as well. The correct answer here is D. Galactosemia. Okay. So when we are saying that when a baby presents to your facility with unresponsive hypoglycemia and prolonged jaundice, it can be as a result of what? Galactosemia. Why? The first one is simple. Hypoglycemia. Well, galactose needs to be converted to what? Glucose. But because we don't have the galactose 1 phosphate uridyl transferase, we cannot convert the galactose into what? Glucose. And so the baby is going to have what? Hypoglycemia. But what is the jaundice also doing here? That is the question we need to ask ourselves again. Now, in conjugation of bilirubin in the liver, it is done by an enzyme known as what? Glucuronidase transferase. But this glucuronidase transferase can only do the conjugation of the bilirubin in the presence of adequate oxygen and glucose. Okay, so this patient is not having glucose but only galactose, and that is not what the liver needs to conjugate the unconjugated bilirubin. And so there's the liver will not be able to what? Conjugate for it to be excreted, and that will lead to a build-up of unconjugated bilirubin in circulation, and hence what? The jaundice. Okay, all right, so that is the answer for this question and the rationale. Now let's look at the last question here. When preparing to obtain a neonatal screening test for phenylketonuria (PKU), the neonate must have received which of the following to ensure reliable results? A feeding of an iron-rich formula, nothing by mouth 4 hours before the test. C. Initial formula or breast milk at least 24 hours before the test. And then D. A feeding of glucose water. Alright, so what do you think is the answer here? So far this is so simple. This is so simple. Okay, this is so simple. Very, very, very simple. Alright, so I hope you got this one correct. The correct answer is C. PKU. We want to see the test. All that we want to see phenylalanine in the blood. So before you do the test, before you do the heel prick to get the blood sample, you must introduce phenylalanine food into the baby so that if it stays without being converted into tyrosine after 24 hours, then we can confirm that there is absence of what? Phenylalanine hydroxylase. Okay, and we know that the breast milk contains phenylalanine. Okay, or some formulas also contains phenylalanine, and so that means that a baby with this condition should not be fed with breast milk or formulas that contains phenylalanine. Thank you so much for staying tuned with Smartness tutorial. I believe you have enjoyed it. If you do, give me a thumb up, give a nice comment, okay, at the comment section, and share the video to your colleagues who are also about to write the NMC exam, or your colleagues in the first years and the second year, because they also need this tutorial. Thank you very much.